So we're just going to end this symposium now with Dr. Cabassa's talk and really focusing again on moving from pilots data, kind of where our work is, now into a more robust intervention. He's going to be presenting some of the work that now it has moved into a full R01, looking at interventions for people with serious mental illness.
Hi. Buenos días.
Yeah.
So I'm also going to talk in English. I have no excuse, but I'll talk in English because I was mandated to. It is always good to be in Puerto Rico, particularly when it's 8 degrees in New York right now and snowing. And my research assistant just emailed me that they can't get to work, and I'm like, oh, that sucks to be you. Sorry. This work actually started in 2009 when we began to figure out how to improve the physical health of people with serious mental illness. And I'll talk a little bit about why that is such an important issue and why that is a disparity. But in terms of the politics of the community, this project and this whole portfolio of research starts with a problematic political issue in our community. And this is actually an interesting story. When I started this work, I was hired by the Office of Mental Health to help assist a center for mental health services research in New York City. And I was hired to begin to work with community agencies to develop interventions and to figure out how to address the physical health of these individuals in northern Manhattan, in Harlem, in Washington Heights, in Inwood, particularly African American and Latino communities. And the first day of my job was to call all the agencies that we had promised funding and told them that we cannot fund them because the financial crisis had started and the Office of Mental Health in New York had cut funding. So that was my first entry into the community, to call all of these agents. Oh, by the way, those $20,000 that we had promised you are gone. And my job is to do community-based participatory research. So from that experience, we began to develop this process of community engagement, and the agencies that have kept up with us in this approach have actually engaged in this type of work, and we're the agency that said, you know what, we understand that that happens, but we still have a problem in our community and we want to continue to work with you and figure out how to do this work. So all of this work comes out of that component, and it's really important to understand sort of the politics that happens and the funding problems that happen throughout this project. So today I'll talk about the health disparities among people with serious mental illness. I'll define what that is. I'll talk about how we use photo voice as an entryway into the development of interventions. And I know there's been already a talk on photo voice, but we use it a little bit differently as a way to really listen and understand from the client's perspective, from the people who are going to receive the intervention, who are going to benefit from the intervention, what is it that they want? What are their voices as we're doing this type of work? And then how that has led to different interventions and to an actual study that we're doing right now. So serious mental illness is basically mental, behavior, emotional disorders. We're talking about the serious type of things, schizophrenia, bipolar disorder, major depression, that interfere with people's major life activities and actually social functioning, serious functional limitations. Around 10 million individuals in the U.S. report a serious mental illness in the past year. It's a small percentage of the population. We're talking about 4% of the adult population, but this is the population that's costing the healthcare system the most. These are the people who are showing up in emergency departments, who show up in prison, who show up in the mental health services. And out of the 10 leading causes of disability in the world, 5 of them are serious mental illness. So these are issues that really impact people's function. A major component is a public health crisis that's happening among people with serious mental illness, that they're dying at a younger age. They actually are dying. If you're in the public mental health system in the United States and you have a serious mental illness, you're more likely to die 20 to 25 years earlier than the rest of the population. And that's due to cardiovascular disease, diabetes, heart disease, and some cancer. And here's some data from a national study looking at psychotic disorders compared to people with no psychiatric illness, and the average age of death is about 8 to 10 years earlier. So we're talking about a disparity not only in the rates of disease, but in actual death, that you're dying younger, and you're not benefiting from the healthcare improvements that are out there in the community. So my interest has always been sort of in this issue of health disparity, racial and ethnic disparities. And then we have issues with serious mental illness. So we've seen two disparities, or two populations that have two major vulnerabilities. Is there evidence indicating that the intersection of these two vulnerabilities place people at even higher risk because you're Latino or African American, plus you have a serious mental illness, compared to someone that doesn't have those vulnerabilities or doesn't have those characteristics? And in a systematic review we recently published, we found some evidence for this double burden, particularly in cardiovascular-related mortality if you've been exposed to antipsychotic medications. So people with serious mental illness, most of the medication they're receiving are antipsychotic medication, which puts you already at risk for cardiovascular disease. And we're seeing higher odds of actually dying from cardiovascular disease if you're an African American or Latino with serious mental illness compared to a white person. We've seen higher odds of diabetes, metabolic syndrome, and actually the metabolic abnormalities that happen with antipsychotic medication. So if you're taking an antipsychotic medication, one of the side effects is you're going to gain weight. And if you're a Latino and African American, you're actually going to gain weight faster than if you're a non-Latino white individual, particularly if it's not managed, meaning if your doctor is not helping you with that type of situation. So we wanted to address that double burden. The issue has been that the evidence is really not very conclusive. It's inconclusive. These are very small studies. Out of 30 years of research, we were able to only identify 30-something studies with really small sample sizes and mostly clinical samples that people are already treated. These are not people in the community. So we really don't know if that double burden actually, what's the extent of that double burden in the community. And one of the major components here is that there's this assumption that once you have a serious mental illness, all other disparities disappear. The mental illness is what really driving that disparity. And our argument is that that's not true. There's actually other components that actually might drive that disparity aside from your mental illness. So the social determinants of health. So the determinants of health disparity among people with serious mental illness, it's this high prevalence of modifier risk factors. So smoking, for example, is really high in this population. The side effects of antipsychotic medications. You also see a sedentary lifestyle. People with serious mental illness also have poor access to high-quality medical care and health intervention. And then the delivery of those health interventions in community section actually is less, meaning that they can't access that those interventions because they're actually not out there in this community agency, particularly, for example, in housing agencies, which is where we were going. So when we started this work, we wanted to partner, out of those agencies that still wanted to partner with us, they wanted to figure out, so what kind of interventions can we actually bring to these agencies to address the health disparities that they're seeing. They were seeing these issues. They were seeing Latinos that have schizophrenia, that are dying for cardiovascular disease, that have diabetes, that have high rates of obesity. What can we do about it? And these agencies was actually very innovative in the sense that we can come up with 20 different interventions. We can figure out how to do that, but we don't know from the client's perspective what will actually work, what will actually engage them in lifestyle intervention, for example, in losing weight or improving the cardiovascular disease. So we wanted to take a step back and actually listen from the client's perspective. So that's where participatory research really comes into play, because it gives us an opportunity to engage the client in this process of understanding what are their actual needs, what would they want. So we began this process of the Health and Wellness Photo Voice project. So the idea was to engage clients in a dialogue about their physical health and wellness. What do you want? If we bring an intervention, will you come? What type of interventions will actually work here? And to generate that community knowledge to inform not only the type of intervention, but how to implement it. These were agencies that were not interested in saying, we're going to do an intervention, we're going to do a randomized controlled trial, and you're going to give us the data, and we're going to leave. They wanted something that they can actually do and will stay in the agency. It's more than just translational research. It's actually implementation science. How do you get interventions in a community agency so that they can actually do it? So what we did, we asked these two agencies to select tenants. These are supportive housing agencies, and I explained why we went there, to choose 8 tenants, 8 from each agency, to participate in this process with us, to engage in this journey with us. And so these were very selected individuals. They're people who are receiving services but are really interested in physical and mental health issues. They're the leaders within the agency in terms of the client population. So this is a select group of individuals that went through this journey with us. Why did we choose supportive housing? So some of you, does people know what supportive housing is? No. No? Good. I didn't know either until I did this work. So supportive housing agencies are agencies that provide, of course, housing, particularly to people who have chronic homelessness, and most of those individuals have a serious mental illness. And they provide housing in the community, so out in the community as an apartment. And some of those agencies have different philosophies of providing that housing. So, for example, most agencies, the condition for you to get an apartment is that you have to go through services. You have to be in a substance abuse clinic. You have to have psychiatric medications. You have to be engaged in mental health services. Other agencies have decided to say, you know what? Housing comes first. We're going to house you regardless of whether you have any type of treatment or whether you want to engage in any type of care. And then once you're engaged in your housing, we will offer you services. And if you want to go, you can go. If you don't want to go, you don't have to go. So there's different philosophies of how to provide housing services to people with serious mental illness, treatment first or housing first. And they're becoming, this type of agencies are becoming a growing sector for housing the homeless. Rather than shelters, it's providing people apartments in the community. There are settings that is beginning to think about how to integrate physical and mental health issues in their service system, because these people have this type of needs. So how do we bring interventions there? The other important component is that they employ peer specialists. These are people who have had lived experiences with mental illness who are employees of the agency, and they're delivering services. These are sort of our community health workers, but in the mental health area, sort of these peer specialists, and they can actually be people who deliver services. And then with the healthcare reform, particularly in New York State, these are the places that actually can partner with medical homes to bring the people into medical services. Because in New York State, the healthcare law is targeting people that are high users of healthcare services, which is exactly these individuals. People that have chronic medical illnesses and a chronic psychiatric issue. Those are the people that we're trying to target in New York State to provide them medical services. So this could be the referral for that and provide funding for this type of work. So why Photo? So what is Photo? Photo is a participatory action research method, as we have heard before, that entrusts people with cameras to document their everyday life and inform social action. And the idea here is photo and voice. So not only that people are taking photographs of whatever is in their community that you're studying, but also what is the stories behind those photos? What do they mean to people? What do they want to share with that? And then to promote a dialogue between the people who are taking photographs. The idea here is to really create an understanding of the community needs from the people in that community, so that then they can inform social action, they can inform policymakers and changes. So it's an advocacy tool in many ways. And there's been many examples in the literature on how to actually do this type of work in different situations. So our community partners, when we started, was Broadway Housing Community, which does this treatment first component. You have to have a case manager, you have to be in treatment in order to get an apartment, or Pathways to Housing, which are the developers of the housing first model. It's interesting now, given the politics of all the things that have happened since 2009, Pathways to Housing is still a partner in this project. Broadway Housing actually has backed away from some of the work that we've been doing because of some financial issues that they've been going through. So that's another component here of participatory research, that agencies also coming in and out of this process, depending on the situations in which they're in. So what we did is, at each agency, we did 6 weekly sessions with these clients. And we brought them in, and it was a 90-minute session. We paid them, we fed them, and we really were there to facilitate this process, not to drive the process. And what happens in this session, people come in, and they have a short photo-elicitation interviews, and I show exactly what I mean. And then we have a group dialogue about those photos. And we do this for 6 weeks. At the end of each session, we step back and tell the participants, okay, what would you like to take photos next? It's all about health and wellness, but what would you like to say? The questions don't come from us, the themes don't come from us, it comes from them. And we do it very democratic, people vote, and say, okay, that's the theme for next week. That's the type of photos that you're going to bring and go out and do that. As a qualitative researcher, all the interviews, all the group dialogues are audio recorded, so we have a record of everything with everyone's consent. And then our group facilitators are taking participatory, are taking field notes of that process with people's consent as well. So the photo elicitation interview is very simple. Here's a photo, the client's in the middle. We have a community member doing the photo elicitation interview, and then we have one of our researchers who's next to the computer doing the technical components. And we really ask this person, they bring the camera, we hook it up to the computer, we see all the photos, and then we ask them, okay, out of all the photos that you have taken, which one best represents the theme for this week? And we go through it, we flip through them, they pick one, and then we ask them these questions. And we have a short conversation about what's going on. At the end, we ask them, can you title that photo? Then we're going to print that photo out, we're going to give it to you with the title in the back, and then you're going to take that photo and we're going to do a group discussion with everyone's photos. And then we're going to sit around a table for 60 minutes and we're going to talk about what that experience is. And we use sort of this type of methodology called the showed component of getting that dialogue going. And what you have here is me facilitating the group, but then you also have a community member actually writing down all the things that he or she is hearing about this component. So everyone sort of understands what's being discussed. And that dialogue is very important because people begin to figure out connections within each other, ideas, experiences around the topic for that particular week. These are the weekly themes that came out, a little bit academic, but all of them are chosen by the individuals. The first week, there's no theme. The first week is an introduction into how to take photographs, the ethics of taking photographs in the community, safety issues. So, for example, do not take photograph of a crime in action, particularly if you're doing the crime. Do not take photograph while crossing the street, things like that. And we really need to express that. And the IRBs, we can have a whole workshop on IRBs on this type of issues. Don't take photos of minors, for example. If you take photo of someone with an identifiable face, you have to have permission of that individual. And we can talk about sort of what those components are. So we use a full-blown qualitative analysis, which we included a community member in our community team for analyzing the data. And we use sort of grounded theory, and I can talk a little bit more about that. This time is running short. This is the strategies we use to make sure that we have analytical rigor, having the analytical team and including a community member in that team, and we pay for that. That was really important. This person read all our transcript, participating in the analysis meetings, provided comments that we wouldn't have thought about. And it was very interesting to see what that person came up with in terms of codes, for example, for coding these interviews, ideas that came up. And then we did all of these components. The most important piece in my perspective was the prolonged engagement with the participant. These are 6 weeks. They're coming every week. They're going to see us every week. And the relationship we build with those individuals is critical for this to be good. And those relationships actually have continued after this. We have really built an understanding not only what we learn from them, what they learn from us, and what they learn from each other was very important. The prolonged engagement of participants was really important. And that's a key element of qualitative research that this type of methodology really helps. We also did presentations to the agency, so the board of directors with the photographs, with community members, with participants, and the photo exhibits. At the end of the day, you have thousands of photos. And you can actually build a really nice exhibit with the actual narratives of those photographs and have the participants present them to the community. So we did several photo exhibits to the community, to the other clients at the agency, at the hospital, which I work, and the New York State Psychiatric Institute. And that was actually very powerful to see those clients out there telling their stories to psychiatrists, to social workers who have in contact with them. And that actually was very helpful to us. So here's sort of who we have, and I'll go through this quickly. We had good participation. Remember, these are people who have serious mental illness. They're coming back. We did this in their housing agency. They've gone to treatment. They're working. And now we're asking them to join one extra group for 90 days. And people did show up. People actually participated in this process, and we have some data to indicate that it is. It's not perfect attendance, but it's pretty good attendance if you look at sort of intervention research with this population. So what did we find? So at the end of the day, we asked a question to the data. So we have your ideas. What type of health interventions would you like to have? What did we learn that people wanted? So the number one thing that people wanted is not have a professional deliver the intervention. We want peers. We want someone who looks like us, who's been through this, to deliver that intervention. I love this quote: the best weapon for a recovering addict is another recovering addict, helping me along the way. They've been there. They're more credible than a professional lecturing us about what to do, like what I'm doing to you here. So that was really important. So a peer-based approach. Help us develop skills. Don't teach us about how to cook better. Don't tell us about what's good or bad. Actually give us particular skills on how to eat better. It's a great quote on someone who said, look, I've been to many nutritional classes. They gave me a recipe. It's for 4 people. I live alone. I end up throwing away food. These people are living with limited incomes. If they don't have, if they're going to lose food, they're going to lose money, why would they cook for 4 people if they live for 1? So really, like, help me cook for 1 individual. That type of thing is what we were learning. And the photos are taken from the participant and thus the title for the individual. Pay attention to the food environment. You're telling us in a nutrition class we have to go to Whole Food. There's no Whole Food around here. We have a bodega. We have a Chinese restaurant. How do we make better choices with what's around? And how do we make that component better? Learn by doing. Don't talk to us. Engage us. Experiential appointments. Like, if we're going to cook something, let's all cook it together. Let's figure out how to do this together. If I don't cook and I go to McDonald's every day, take me to McDonald's and show me what's our better choices that I could take. That type of thing in experiential learning that people really wanted to. They want to engage, but they really want those skills. Physical activity was very important, both for physical and mental health. People wanted things that helped them with their mental health issues. That doing exercise was actually very helpful for people who are depressed, for people who are in a psychotic episode, for example. Make it fun. Make it social. One of the things that came out of this project is they started a walking group. The same group that we had every 6 weeks, they ended up having a walking group after we left, which is really important for them. They were smoking during this walking group, but at least they're walking. Okay? They're out there. An interest in a weight loss program. Bring people here. We see this. I mean, these are people living in the community. They see gyms around. Why can't you bring a weight loss program to our agency and have us figure out how to engage in that weight loss program? So that was a really important component for us. So what Photo-Voice helped us is the format. We learn about the format of the intervention. We learn about the content. And then we learn about the methods that we should provide. And we have used that data all throughout the process in which we are now. So this has helped us choose an intervention, adapt the intervention, and test it within this agency. These are very small, like any other research. It's a small exploratory study. It's a small purposive sample. These are people. These are the best of the best in that agency. So we need to be very aware of that as we move forward. And it's constrained to 2 housing agencies who are committed to do this. They want to do a health intervention at their agency. So we need to make that very aware. Not every agency will have that. So what has happened is that we did this Photo-Voice project. We then search for funding left and right under every rock that we can turn and find pilot funding to actually test an intervention at a housing agency delivered by a peer. And we actually use the diabetes prevention program, the group lifestyle balance intervention, to test it, to see if this is feasible. Are people going to show up? Is it acceptable? And we have begun to do that. We finished that test last summer, and then we applied for, there was an RFA that came out for this particular issue in the National Institute of Mental Health, and we applied for that intervention. The idea was to actually test interventions in the community with the community. So we had an argument or a framework where we're at, and we were able to receive funding, not only to test the intervention, but to actually test the implementation of it. So how are the agencies actually doing this type of work? How are they integrating it into their services? And right now we've received funding for this hybrid type 1 design, which is a hybrid between effectiveness trials and implementation research, in which we are actually blending these two areas of research. We are in year one right now. We're actually understanding what's the context within that agency. What is it that they actually are doing? What's usual care? Then we are going to intervene with an effectiveness trial, and then we're going to interview them again to see how have our trial changed the agency and how the agency has changed our intervention. And all of this is being delivered by peer specialists in the community. So how do we train? How do we engage those peer specialists? And one element that we've been very lucky to add is participant observation throughout the entire process. We're actually sending students to the agency to conduct observations throughout the entire process, 4 or 5 observations a month at each of the sites throughout the entire 5 years to really get a sense if things are actually changing or not, and how are things actually improving. The other component was that we're comparing this to usual care at a housing agency. What is usual care? What will they be doing? So we really wanted to understand what that is so that we can have a comparison between our intervention and usual care and really capture whether it is better or not. And that's the point of this study, to see if it is better, how is it better? And if it's not, why is it not better? So in the end, what I've learned from this work is that addressing health disparities, particularly people with serious mental illness, requires that community engagement and social action. It needs to go from the ground up and from the bottom up as well. You need client input, and participation is critical for developing intervention, and then how do you going to implement it? Because those are the people who are going to actually have this intervention. And then participatory methods like photos can generate a lot of community knowledge that's essential for reducing those health disparities, not only on the need, but also on the strengths that that community has in order to do this type of work. So this is the team that have provided us funding. This started with the New York State Office of Mental Health. NIMH has been very helpful as well. And we have a great collaborator team, both community members as well as students who participated in this work and continue to participate. And what's interesting is that this list has changed. Every time I do this presentation, people come in and out of this collaboration, and that's the whole beauty of this type of work. And new collaborators are emerging as we do this work in New York City. So thank you, and we'll take some questions.